Chitra, am I audible?
Yes, you are. You can start now. Arun, please.
Okay. Yeah. Are we ready? Ready to go? It's 7:54. So good evening, everyone. Welcome to this Wednesday clinic that is being conducted monthly by the Indian Thyroid Society. We, as you know, Indian Thyroid Society was established in 2003 and registered in that same year. And it's a organization which has endocrinologists, nuclear physicians, endocrine surgeons, physicians and surgeons, and ENT surgeons as members. And ITS is a member of the IOTA, which is the Asia Oceania Thyroid Association. Currently, ITS has about 2,000 members in its role. The founder president is Professor R.V. Jayakumar, and current president is Professor Sarita Bajaj, who is with us tonight. And the past president was Professor Rajesh Ashput, and the current secretary and treasurer are myself and Lini. The committee, the executive committee has Dr. Kimgiri Shao, Dr. Pramila Kalra, Dr. Sujay Ghosh, Dr. Shashank Joshi, Dr. P.K. Jabbar, Dr. Krishna Sheshadri, Dr. Mohammad Riaz, Dr. Sushil Gupta, and Dr. Ashraf Ghani as its members. The aims of Indian Thyroid Society is to organize academic activities for the healthcare professionals and especially people who have interest in thyroidology, encourage research in thyroidology, promote public education awareness about thyroid disorders, and also encourage publications in our flagship journal, which is the Thyroid Research and Practice. This is state-of-the-art publication with an online facility. The Indian Thyroid Society also awards the fellowships of the society and encourages membership of the society. We have, over the last couple of years, conducted CMEs, updates, regular symposium conferences, and the highlight over the last year has been the weekly thyroid clinics, which has then been fortnightly and now is monthly. And this has a variety of programs, which includes journal clubs, case conversations, monologue, duologue, panel discussions, meet the professor sessions, quiz, which has been a highlight almost every week, every meeting. The quiz has been very well received. The Thyroid Awareness Week, as you all know, is celebrated worldwide from May 22nd to May 28th. And the World Thyroid Day is celebrated on May 25th, and every year we have some scientific function, scientific program to celebrate it. And the Thyroid Awareness Month is celebrated in January. The ITS does provide annual grants for original research into thyroid and related disorders. The research grants are available through the website. You can check on the website. There will be an announcement every year as to the date of submission and further details. So you just need to visit the website that is given below. The Thyroid Research and Practice is the flagship journal of ITS. It's published twice a year in print and online. There's a quick turnaround time. The electronic copies are available ahead of print. So we all encourage you to send articles onto the journal. The fellowship is a new program that has been started by the ITS. It will be awarded to ITS members with expertise and experience in the field of thyroidology. This will be selected by an expert panel, and the eligible members will be conferred the Fellow of Indian Thyroid Society. The publications from Indian Thyroid Society, the original one was the Clinical Manual of Thyroid Disorders. The first edition, edited by Professor R.V. Jayakumar, came a few years back. There have been guidelines on thyroid dysfunction pregnancy, thyroid dysfunction, managing thyroid dysfunction during pregnancy, and hypothyroidism and diabetes. There have been many other guidelines as well, which includes management of subclinical hypothyroidism, management of dyslipidemia and thyroid dysfunction, as well as management of depression and thyroid function. The current publications or the upcoming publications, of which the ITS clinical textbook of thyroid disorders is now complete. The chief editors are Dr. Sarita Bajaj and Dr. Rajesh Ashpur. This will be published and will come into be published in May during our ITSCon 2023. So it is something to look out for. The upcoming guidelines, we have guidelines coming up on subclinical hypothyroidism. There is a review of the revision of the thyroid disorders in pregnancy guidelines, and the thyroid carcinoma guidelines is also expected in the next year. Please visit our website, the link to which is given below. You can access the ITS journal through this. There's a record of all the academic events. I think that would be very interesting. I mean, if you go in, all the recordings of the scientific program over the last year is available there. So when your free time, please go and watch that. It will be very, very informative and useful. And the online membership portal is also accessible through the ITS website. The membership is open to all MCA registered modern medical practitioners in India to become life members. There are two types of life membership. The full life membership, which is open to specialists in the field of endocrinology, endocrine surgery, and nuclear medicine. And the associate life membership, which is open to all other registered medical practitioners. The applications are invited online on the ITS website, and the details, again, you can access from this website address. So please do go and check out the website, and please join us in making ITS a successful organization. Thank you. I think now we can move on to the scientific program for this evening. Smita, you can project the slides and we can. So the first talk for tonight, I mean, there are two case presentations by Dr. B. Shravya. So to start the proceedings, let me invite the chairperson, Dr. Rabindranath Mehrotra, who is a senior consultant. Can you just show me the slide, the previous slide? Yes, thank you. So he's a senior consultant in the Department of Endocrinology, Apollo Hospitals, Hyderabad. He's a DM Endocrinology and is a member of the Endocrine Society USA, Indian Medical Association, Endocrine Society of India, RSSDI, ISBMR, and the Pediatric and Adolescent Endocrine Chapter of IAP. So over to you, Dr. Rabindra Mehrotra, to take the proceedings further.
Thank you very much. I would initially like to thank the Thyroid Society for giving me the opportunity today. And today, my pleasure to introduce the moderator. We have Dr. none other than Uday Phadke. He is the director of. Yeah, I'm audible. Yeah. So as well, it's a pleasure to welcome Dr. Uday Phadke, and the director of endocrinology and diabetes, Shadri Group of Hospitals, Pune. He's MD, DM, and DM and member of Endocrine Society of US. He's a publication and peer-reviewed international journals, chapters in RSGI textbook of diabetes and endocrine manual. He is a proud recipient of Srimati Bhandarkar Award for Academic Excellence. He's a part of the team awarded the Vivian Puniska Scholar Award by ADA for conduct of cosmetic study of bariatric surgery in diabetes in India. And he's also an avid mountaineer and nature photographer. Welcome, Dr. Uday Phadke.
Hello.
Yeah. The next is Dr. Lohit Kumar. He will be the quiz master for today. He is assistant professor of Department of Endocrinology at SDM Medical College, Dharwad. He is a DM Endocrinology and has got area of interest in thyroid, diabetes, pituitary, and growth disorders. He has published various chapters in various textbooks, paper and poster presentation, and national conferences. So I welcome Dr. Lohit to being a good master today. And today, then we will be starting the proceedings. Dr. Shravya will be presenting the first case, and we'll take up from there. Dr. Uday Farke, anyone want to say anything?
So I just wanted one thing about the flow. When Dr. Shravya is presenting her case, we first complete the case and then go to discussion, or do I intervene in between, ask questions, ask clarification? How would be the flow?
I
Yeah,
think
you
it'll
can
better.
ask anything in between. It's like a normal, just a case presentation.
All right.
Yeah, you can
Sure.
interrupt in between, but you just have to keep the time in mind as well, because we would like to finish by 9:15, but it does usually stretch a little into 9:30-ish. So we have the timelines for the first case, then the 10 minutes for a quiz, then another second case, and then we have the quiz answers. And because the Thyroid Society conference is also coming up, we have a little add-ons for this program in particular. I hope I've clarified that.
Sure, no problem, ma'am.
Thank you. Thank you.
Dr. Shravya?
Yeah, please go ahead.
A very good evening, everyone. I'm Dr. Shravya, first year BMB resident from Apollo Hospitals, Jubilee Hills. Today, I'm going to present a first case, a case of hyperthyroidism with young onset hypertension. 32-year-old female who presented with the chief complaints of weight loss of around 4 to 5 kg for past 3 months, increased appetite and excessive sweatings, palpitations, feeling anxious for the past 1 month. By the time she came to us, she was started on tablet carbimazole 10 mg twice a day. She has no history of any recent fever, sore throat, or upper respiratory tract infection. Past medical history, she's a known case of hypertension, diagnosed at her 24 years of her age. She has a history of occasional episodes of headaches and palpitations. She has a history of preterm delivery at 28 weeks in view of probable eclampsia. She had seizure at the time of delivery, for which she underwent emergency lower segment cesarean section. She had a rise in her blood pressure during her surgery, which was managed with IV anti-epileptics and antihypertensives. This is the history which she could recollect. There were no proper medical documents available with her. Drug history, she was on tablet nifedipine 20 mg twice daily and metoprolol 50 mg once daily. After the delivery, she had intrauterine death of the baby. There was no live baby. So on further asking about her family history, she has an elder sister who has a Graves' disease, diagnosed at her 32 years of her age. Father is a known case of type 2 diabetes. Mother is a known case of hypertension, diagnosed in her late 40s. Paternal aunt expired at 50 years of age due to the brain tumor. The exact etiology of the thing could not be is not known by the patient. Cousin has a CKD at 34 years of age, who is on maintenance hemodialysis. She doesn't know the exact etiology of the thing. On general physical examination, the patient is conscious, weight of 47.7 kgs, pulse rate of 102 per minute, regular. Blood pressure, right upper limb, it was 160 by 100 millimeters of mercury. Left upper limb, it's 150 by 90 millimeters of mercury. There's no change in the blood pressure between the two arms. Eyes, there's right eyelid retraction with the right upper lid lag. There's no congestion, redness, or swelling of the eyelids. The fine tremors of both the hands are present. On palpation, there is a diffuse firm thyroid gland. Her biochemical during the first visit, her weight was 47.7 kgs and blood pressure of 160 by 100 millimeters of mercury in right upper arm in sitting position. Pulse rate of 100 per minute. TSH of 0.001. Free T4 of 4.2 nanogram per DL, which was around 3 to 4 times the upper limit of normal. Free T4 of 16.78 picogram per ml, which is approximately 4 times the upper limit of normal, which is suggestive of hyperthyroidism. her TSH receptor antibodies were positive. She was continued on neomercazole 20 mg per day. During her next follow-up visit, there was no improvement in her weight. The blood pressure was 130 by 90 millimeters of mercury and the pulse rate of 112 per minute. There was an improvement in her free T4 and free T3 values, which was significantly decreased. And she was continued on neomercazole 20 mg per day and the antihypertensives which she was using, that is nifedipine 20 mg twice daily and metoprolol 50 mg once daily.
So, Dr. Shravya, can I ask you one thing? What is the significance of this TRAP test? How would you use it really in therapy?
The significance of TRAPs is that to tell us whether the etiology of hyperthyroidism is one thing. And in the treatment part, it will just let us know and in what way we can treat the patient with what is the definitive treatment which we can plan. If the patient is having the thyrotoxic symptoms, we control the symptoms and the thing with the antithyroid drugs. And later on, depending upon the clinical symptoms, whether if the patient is having only mild ophthalmopathy or without any ophthalmopathy, we can plan the definitive management with radioiodine.
So does a high TRAP tell us anything about the prognostic aspects of medical therapy?
Yes, sir.
About remission?
Yes, sir. If there are high TRAPs, the chances of relapse is more. Like chances of patient going into remission is less, and if they go into remission also, they have a chance of relapse.
Okay. Would there be any other consideration because she, in pregnancy, maybe?
Yes, sir. If the TSH receptor antibodies are positive, they cross the placenta and they can have the fetal thyrotoxicosis, and they can have the fetal.
Shravya, why did you continue with only 20 milligrams despite the fact FT3 was high, and whether you did ask her to stop iodized salt?
Yes, sir. We asked her to stop the iodized salt and we continued with the 20 milligram per day because she was started with 20 milligram per day recently. Like it was only 3 days back when she came. So we continued the same dose and we asked her for the review the situation after a month. So as there was an improvement in the thing, we expected that the dose was sufficient.
No, with high T3. This is done after 1 month, the next
Yes.
investigation?
Yes, sir.
So you still have high FT3, no? Was she symptomatic, asymptomatic at that time?
The symptoms, the clinical symptoms got improved after a month, sir. Like
so that they will, but did she still have symptoms and signs of mild hyperthyroidism?
The symptoms which the weight, there is no improvement in her weight, but her appetite, the palpitations and sweatings got improved a lot after starting her on treatment.
So would you have started treatment differently? I mean, considering the severity of thyrotoxicosis, would you have started, if you had seen the patient first time, in a higher dose than 20 milligrams? Because
she's
20
very much with this high FT4, the 20 is not sufficient. We should start with the higher doses initially.
Okay.
During her next follow-up visit after about a month, her weight was 48. There was an improvement of around 1 kg in her weight. Blood pressure was 150 by 90 and the pulse rate of 82 per minute. There was an improvement in her free T4. And on routine investigation, she had an impaired fasting glucose and HbA1c was normal 5.6. And the dose of neomercazole was reduced to 15 mg per day as there is an improvement in her free T4. She could not get her free T3 report at that time. After about a month, there was an improvement in her weight of around 3 kgs and the blood pressure was 140 by 90 and the pulse rate of 106 per minute and TSH of 5.73 and the free T4 was around 1 nanogram per day. The dose of neomercazole was put on 10 mg per day. After about a couple of months, there was an improvement in her weight of around, she gained around 6 kgs after starting her own treatment. In spite of improvement in her clinical symptoms of weight and appetite, and she persistently had the symptoms of occasional palpitations. Blood pressure was 160 by 90 millimeters of mercury and the pulse rate of 100 per minute. When we as her clinic BP was on the higher side, when we asked her to get her home BP recordings, even the home BP recordings were on and off on the higher side, with the maximum home BP reaching around 150 by 100, with the minimum of around 130 by 80. The TSH of 2.53, the free T4 was same 1 nanogram per DL, and the dose of neomercazole was put on 10 mg per day. After about a month, there was an improvement in her weight and the blood pressure of 140 by 70 and the pulse rate of 98 at the TSH of 4. And the dose of neomercazole was reduced to 5 mg per day. In spite of her improvement clinically in terms of weight and her symptoms in the form of sweatings, only she had the higher BP recordings during her clinical hospital visits and in the home. In the month of December, her blood pressure was 120 by 80, pulse rate of 96, with the TSH of 3 normal TSH and the free T4 of 0.92 nanogram per DL and a dose of neomercazole of 5 mg per day. On reviewing her past medical history, because as she's having the high home BP recordings and occasional palpitations with high clinic BP recordings in the clinic, she was reviewed. We reviewed her past medical history. She was evaluated for the cause of hypertension by other specialties in the by other specialists in the past. As she had a difficult delivery with high BP at the time of delivery, she was advised surrogacy by other specialists. She was evaluated by the cardiologist. Her 2D echo was normal and bilateral renal artery Doppler was normal. There was an ultrasound abdomen was normal. There was normal renal size and echo texture. In spite of her improvement in her clinical symptoms in the form of in terms of weight and sweatings, and with the persistent high BP recordings in clinic and in the home, we have evaluated for her endocrine causes of secondary hypertension as she's a young female. Her 24-hour urinary cortisol, plasma renin activity, and aldosterone were normal. 24-hour urinary fractionated metanephrines were normal. 24-hour urinary fractionated normethanephrines were around 6 times the upper limit of normal. Whereas plasma metanephrines and plasma-free normethanephrines, plasma-free normethanephrines were approximately 9 times elevated. So this shows the biochemical evidence of norepinephrine secreting pheochromocytoma or paraganglionoma. It could be. So as there is a biochemical confirmation.
I have just a quick question here. So you have done both the urinary fractionated as well as the plasma. So this becomes a little costly. So why did you do both?
First, we have asked only for the screening of a 24-hour urinary cortisol, fractionated and fractionated metanephrines and normethanephrines. As her it was elevated just as a part of confirmation. We did a plasma. It is plasma-free normethanephrines.
So, on retrospect, what do you think is a slightly better test? The plasma metanephrine, normethanephrine, or the urinary?
Plasma one has more sense. Plasma one has a more sensitive. More.
So then, wouldn't you use a more sensitive test for screening?
Yes, sir. But clinically, she is not. Even we are thinking about. We need to rule out the Cushing's also in this case. We did clinically.
No, I agree
she's
with
not
all that. But if you want to do a test, you will need a test which is more sensitive, right?
Yes.
So maybe plasma is slightly better. So did you also have 3-methoxytyramine values in this?
3-methoxytyramine was not there, sir. Actually, she could not get it. Only these two values were there.
Okay.
As there was a biochemical evidence of norepinephrine secreting ring, we proceeded for the radiological testing. CT abdomen with the triphasic study was done, which shows 26 into 23 mm, brilliantly enhancing mass lesion with central non-enhancing area within the left adrenal gland, with a partial double moiety in the right kidney. This is the image which is showing the peripheral enhancing lesion, which is inhomogeneous structure of around 2.5 centimeters in the area of left adrenal gland. It was done outside, sir, so they did not mention about the proper HU values, but clearly it is peripheral enhancing lesion, inhomogeneous structure. It is not adenoma. Adenoma will be the homogeneous structure. This is the image which is showing her left adrenal lesion, which is peripherally enhancing and inhomogeneous structure. So showing the partial double moiety of the proximal 1/3 of the ureter, which was an incidental finding in her case. So there is as there is both biochemical evidence of norepinephrine secreting pheochromocytoma with the radiological confirmation.
Dr. Shravya,
Hello.
yes. So why is metanephrine not elevated? Why are you getting only normetanephrine here? So what is the traditional teaching about meta and normeta?
Adrenal lesions will have more of metanephrine secreting ones, sir. But VHL have adrenal lesions without, it is norepinephrine secreting ones. Mostly the adrenal.
Go on.
Adrenal lesions will be the metanephrine secreting ones, sir.
So were you surprised to see this report? That the normeta is so grossly elevated, but the metanephrines are normal?
Yes, sir. But there is a possibility of in VHL, the tumor will be the norepinephrine secreting ones. Though it
Do
is
you
an
think this is VHL? Were you thinking of VHL here?
Probable VHL, sir, because there's a family history of brain tumor in her paternal aunt with a cousin of CKD. The etiology is not known, but probable with on reviewing her family history, it could be a VHL.
Did you look at her retina?
Retina was done, sir, because it's a part of her eye exam, Graves mild ophthalmopathy. She underwent ophthalmological screening. The retina was normal, sir.
So how many other pheochromocytomas have you seen up to now? Do you remember their biochemistry?
Yes, I've seen like 2 cases till now, sir. One is.
And did they have the same results? Normetanephrines raised?
No, sir.
You don't remember. Okay, so you will have to read this up because most patients, even though they have adrenal pheos, will still have normetanephrine elevated. This concept of pure metanephrine elevation in pheo of adrenal region tends to be true for MEN2 lesions. But for other isolated pheochromocytomas, they may not be completely functional or fully mature, and they still cause more of normetanephrine. So they may not be fully mature enough to cause metanephrine production from normetanephrine. So you will find that most adrenal pheos will still have normetanephrine elevated. So it's not a very odd thing to note. Okay, go on, please. Yeah, please go on.
As there's a biochemical evidence and the radiological evidence, there was an adequate preoperative preparation was done with the alpha blockade. We started with phenoxybenzamine 10 mg twice a day. As she was already on nifedipine 20 mg twice daily, we have continued the nifedipine and we have removed her metoprolol and added increased the dose of phenoxybenzamine to 50 mg per day in divided doses. We have reviewed her blood pressure every 3rd day. There was difficulty in control. She has persistent palpitations after stopping the metoprolol. So we have gradually added the metoprolol in the smaller doses of 12.5 mg. After adequate alpha and beta blockade, the tablet carbimazole 5 mg once daily was continued. We maintained adequate extra salt intake of more than 6 grams, and adequate hydration was maintained. She was we periodically monitored her blood pressure and pulse rate. She underwent robotic left adrenalectomy in the first week of December. There was no intraoperative hypertensive crisis. She was postoperatively managed with IV fluids and supportive care in the ICU for a day. The blood pressure, pulse rate, and the blood sugars were monitored. All were fine, and she was hemodynamically stable in the perioperative period. This is her intraoperative notes, which is showing her intraoperative blood pressure monitoring. The maximum BP rose up to 130 by 90 millimeters of mercury. There was no intraoperative hypertensive crisis. The histopathology report, there was a macroscopic description. The cut surface of the large tissue pieces was well circumscribed, shows well circumscribed tumor, measuring of approximately 2.3.
Go ahead further. For paucity of time, maybe you could go to the microscope histopathology. Yeah.
Microscopic description shows a neoplastic tissue composed of nests of neoplastic cells enlarged with enlargedly moderately pleomorphic cytoplasm. This is a low power view. This is a high power view, which shows nests of the neoplastic cells with pleomorphic nuclei and eosinophilic cytoplasm. The focal significant nuclear atypia is identified. This is known as a Zell-Ballen pattern, where there is a group of the cells. This is the immunohistochemistry, which showed strongly positive for chromogranin. Coming to the discussion, the Graves' disease.
Okay, so just very quick couple of questions. Okay, so now you said you had suspected VHL, right?
Yes.
In VHL, do you get only adrenal pheochromocytomas?
Yeah, VHL, we have adrenal pheochromocytomas.
Only?
More of
Can you
adrenal
have extra?
more of adrenal pheochromocytomas we see in VHL, sir.
Okay, but you don't know whether it is VHL. Considering the large amount of discrepancy between normeta and meta,
Yes.
did you feel you should also do some other functional imaging study apart from CT scan?
Yes, sir. We have actually asked her to get a functional imaging test done. But in this case, the lesion is less than of around 3 centimeters. Ideally, if we get this, as she's a younger girl with a positive family history, if we could get it done, that will add an extra advantage. We have advised her to get it done, but she was not affordable to get it done. So we did not.
But you would get it done, right?
Yes.
And what would you do?
Like, it is not, as the size of the lesion will not recommend us to get next functional imaging done, sir. But on considering her positive family history, it would add an extra advantage if we get it done.
So what test would you get done? If it was
Gallium
available
dotonic,
to you?
gallium dotonic
What about
scan.
MIBG?
We can get an iodine 123 MIBG also done.
We can do anything. What would you do?
So gallium dotonic would be ideal, sir. Usually they tell that if we plan for the iodine 1 therapy at the later date, we need to get an iodine 123 MIBG scan done. But the sensitivity of the gallium dotonic is more when compared to iodine 123 MIBG.
Okay. All right. Go ahead.
Discussion. Graves' disease is considered to be an autoimmune disease. It is a combination of environmental and genetic factors, including the polymorphisms in HLA-DR, CTLA4 and PTPN22, which contributes to the susceptibility to Graves' disease. Pheochromocytoma is usually revealed by paroxysmal or permanent arterial hypertension with the classic symptomatic triad of headaches, palpitations, and sweatings. It has a prevalence of 0.1 to 0.6 centimeters, 0.1 to 0.6%, with the incidence of 2 to 8 cases per 1 million people. These tumors may arise sporadically or may be inherited as part of multiple endocrine neoplasia type 2A or 2B, which are associated with hyperparathyroidism, medullary thyroid carcinoma. In 2B with mucosal neuromas, Marfanoid habitus, and medulated corneal nerve fibers and megacolon, or several other syndromes like von Hippel-Lindau, where we have retinal and cerebellar and spinal hemangiomas. Neurofibromatosis type 1, where they have neurofibromas, lesion nodules, axillary flecting, and bony lesions. The association of pheochromocytoma and Graves' disease is exceptional. Paschke et al. And Abbey et al. Reported relapse of Graves' disease in patients with pheochromocytoma. They suggested that increased catecholamines in pheochromocytoma acts as an exacerbating factor for Graves' disease. As the thyroid gland is richly innervated by the autonomic nerves, the increase in circulating catecholamines stimulates the basal thyroid hormone secretion by means of alteration in the immune system. I'll be discussing further. In some patients, adverse events precedes the onset of Graves' disease, suggesting that stress plays an important role as an initiating factor for the disease through catecholamines. Additionally, it is assumed that the catecholamines may modulate the immune system. The catecholamines act through the beta-2 receptors on the antigen-presenting cells. It drives the antigen-presenting cells in the form of the naive CD4 T cells. It drives the differentiation of naive CD4 T cells towards the Th2 cells, and it inhibits the Th1 cells. These Th2 cells are responsible for the production of for the humoral response, where they produce antibodies which acts on the thyroid gland. On the diagnostic level, the overlapping of symptoms involved in most part in the two pathologies of hypercatecholaminemia may mislead the diagnosis of one or the other of the two pathologies. However, the outcome of one or the other may be fatal during any invasive procedure. So these are the few case reports which shows a Graves' disease allied with multiple pheochromocytomas. In this case report, they have discussed about a 24-year-old female with a no past cardiovascular history who presented with accelerated hypertension, intense headaches, palpitations, sweatings, agitation, recent weight loss. On admission, she has a febrile episode with fever, exophthalmos, and firm homogeneous goiter with the background history. Initially, they thought it is the thyrotoxic crisis, and biochemical investigations were suggestive of hyperthyroidism. As a part of a routine thing, they did a whole body CT, which showed around 3 centimeters bilateral adrenal and retropancreatic masses. Where they further proceeded with the biochemical investigations, it was suggestive of normetanephrine secreting 1, which was high normetanephrines. This is another case report where the Graves' disease was accompanied by pheochromocytoma. In this case report, they've discussed about a 45-year-old woman for the evaluation of right adrenal incidentaloma. She has a history of palpitations, nervousness, weight loss of 6 kgs in around 1 month. She was diagnosed with Graves' disease and was treated with antithyroid drugs and the beta blockers. She got the chest X-ray done initially. It showed solitary pulmonary nodule. On further evaluation of that nodule, they did a CT chest where they found a right adrenal tumor, right adrenal incidentaloma. On the part of the workup of her right adrenal incidentaloma, they did a biochemical investigations. The 24-hour urinary lab measurements of catecholamines were normal on 2 occasions. So they further proceeded with the right adrenalectomy, but the final pathology was suggestive of pheochromocytoma. Although this case report finally shows that the conventional method for detecting pheochromocytoma is to identify an increase in urinary catecholamines, physicians should be aware of the possibility of false negativity of this test. This is another case report of relapse of Graves' disease in a patient with pheochromocytoma, where in this case report, the patient has a remission of Graves' disease for about 2 decades. During her preoperative evaluation of pheochromocytoma, she was found to have hyperthyroidism, where she was treated with antithyroid drugs. They may suggest that possible involvement of excessive catecholamines and beta adrenergic receptor activation may favored in the relapse of the Graves' disease. These are the few other case reports. Brief discussion on the secondary hypertension, whom to evaluate for the secondary hypertension. Early onset of hypertension in less than 30 years of age in patients without any other risk factors like family history or obesity, and increased BP in prepubertal children. In our case, she is an young girl with a hypertension at 24 years of age. Resistant hypertension is the BP of more than 140/90 with the 3 antihypertensive drugs. One among them is diuretic. Severe hypertension of 180/110 millimeters of mercury or hypertensive emergencies, or non-dipping or reverse dipping of the BP, and presence of target organ damage like left ventricular hypertrophy or hypertensive retinopathy. So the endocrine causes of hypertension, thyroid disorders constitute around 1 to 3%, whereas few of less than 0.5%. And the rest all are the primary hyperaldosteronism, congenital adrenal hyperplasia of 11-beta-hydroxysteroid dehydrogenase deficiency, Cushing syndrome, or apparent mineralocorticoid excess, where there is 11-beta-HSD type 2 deficiency, or secondary
Dr.
hyperaldosteronism.
Shravya, what do you think currently is the most common endocrine cause of hypertension?
Primary hyperaldosteronism.
Yeah. So it is much more common than what you have reported here, which is 12%. So it's increasingly thought that aldosteronism is a missed entity in our workup. Go on, please.
Pathogenesis of hypertension in hyperthyroidism, they will have an increased autonomic nervous system hyperactivity due to increased T3, increased beta adrenergic activity. There will be increased heart rate and increased cardiac output. There will be activation of renin-angiotensin-aldosterone pathway and the endothelin-1, which is responsible for the vasoconstriction. The effects of pheochromocytoma on the cardiovascular system and the cardiac, it can have arrhythmias, rhythm disturbances, ischemia, myocardial ischemia or infarction, cardiomyopathy, which can be
I think
hypertrophic
you'll have to
dilation.
wind up for lack of time. We'll have to go to the second case as well. So anything very specific that you want to mention? Can I ask you one question about the perioperative control of pheochromocytoma? You said you used phenoxybenzamine, right?
Yes.
So what kind of drug is phenoxybenzamine?
Is a non-selective alpha blockade, oral non-selective alpha blockade.
So what are the drawbacks of alpha blockade when you use it in perioperative control? What is the advantage of a selective alpha blockade, like say prazosin?
The difference between the thing is the availability issues. Of phenoxybenzamine is costly and it's not easily available, whereas
so you said your patient had money issues, so why did you use a more costly drug which is less available rather than say maybe prazosin?
As it was available, it will be better to have a non-selective alpha blockade.
Are there any cons of using alpha blockade in perioperative control? Pros, you know. What about the cons?
The hypotension risk is like they have a chance of post-operative hypotension.
Which can be quite sustained.
Yes.
So are there any other regimens to control their blood pressure perioperatively?
Yeah, during the perioperative period, yes, non-selective alpha blockers we can use, and the calcium channel blockers. And during the
can we use them?
Yes, sir,
do they do the same?
We can use the calcium channel blockers, sir.
Okay, we can. So there are articles now coming from India which have compared calcium channel blockers with alpha blockade and shown to have exactly the same results. So it is a good possibility that we can use other drugs as well without the possibility of having severe intraoperative hypotension. Availability of phenoxybenzamine is an issue. So all these factors.
Yes.
All right, fine.
Post-operatively, her
Controlled,
after about
right?
6 weeks, 24-hour urinary fraction to normetanephrines were normal, sir. And her thyroid profile was also like the free T3, free T4 was normal. She was maintained on 5 mg per day. We have asked her to get a genetic testing done, which is awaited. Like we asked her to get it done. She did not come for the follow-up yet.
So should you do a genetic testing for all pheochromocytomas?
Genetic testing for all the pheochromocytomas, like there are few indications for getting a genetic testing done, sir. Like if they present with paraganglionoma or with the clinical features suggestive of syndromic features, or bilateral adrenal pheochromocytomas, or unilateral with positive family history, and unilateral with the age of less than 45.
So previously it was typically described as a rule of 10. So 10% are genetic. Do you think
yes.
that number has changed now?
Yes, sir. Nowadays, more of the genetic component, if we try to find out the genetic.
So ideally, if, of course, it all boils down to economics, but if possible, even sporadic pheochromocytoma should be subjected to genetic testing, because you don't know really whether this is the first index case. Family history is not always available.
Yes.
So at least if this is the index case, you can use this kind of genetic screening for the offspring or the siblings or whatever. So genetics is much more common than it was thought to be previously. Okay, all right, sure. Thank you.
The learning point from this, sir.
Last question. Did you consider radioactive iodine therapy for her?
Sir, as now her thyroid hormone levels are fine, and she's off her antihypertensive medications, and she's about to plan her pregnancy. So we can advise her, like we have advised her.
Can or will?
Will, sir. Like
you will.
Because she's not, we'll ask her to delay her pregnancy for a period of around 1 year. And for a definitive cure of her Graves disease, she has only mild eye disease.
That will be important, right? See, previously everyone thought that she can never conceive.
Yes.
Now, after the cure of her hypertension, she is now clearly in a position to conceive now. So you should give her the best possible outcome with cure of her hyperthyroidism as well.
Yes. Yes.
Plus, of course, your TRAB is so high, so she's unlikely to go into spontaneous remission with medical therapy. So you will plan a radioactive iodine therapy, correct?
Yes.
Okay. All right. Fine. Thank you.
Thank you, sir.
I think we can invite the comments from the audience or the teachers.
I think, Rabindra, there are questions in the chat box which should be addressed, please.
Yeah, I can see one of them.
Yeah.
Dr. Molly is asking, tachycardia would be maybe either Graves or pheochromocytoma. So when you would start beta blocker, and what is the drug of choice? Shravya?
Sir, I could not see that question.
I am saying tachycardia would be either from Graves or pheochromocytoma. Remember which we faced in the patient. So when you will start the beta blocker, and what is the drug of choice?
Tachycardia, maybe due to the Graves or pheochromocytoma, sir. Like if we think that if he doesn't, as this patient already has a non-selective beta blockade, like cardioselective beta blockade metoprolol, so we did not consider her adding on any beta blocker, sir. But it will be a tricky situation if we doesn't know about the cause of her hypertension is pheo. If we put her on non-selective beta blockers, they can land up in hypertensive crisis. If you put them on non-selective beta blockers like propranolol.
We basically had withdrawn the beta blocker initially as the pheo was confirmed, and we put them on phenoxybenzene. The heart rate went very, very high. We had to prematurely start the beta blockade. We didn't want to start it, but we had to start in between. Normally, we wait up to the end, then only start. But here we had to initiate and come up early with the beta blockade. We use the metoprolol only. We didn't use anything else because she was using it from before. She was comfortable with that. So we restarted metoprolol, but a little earlier than what we would normally like to start in FU. Then the second question that we can see now is, may I know what about thyroidectomy for this patient? This patient TRAB is high and also has mild eye disease and wants to conceive. Shravya?
Actually, this is also one of the possibilities that we initially thought to get it. Like we have an option of getting the 2 surgeries at a time, but it is a tricky situation because how the FIO will behave during the intraoperative period in terms of our hypertensive crisis and everything.
You really considered both the surgeries at the same time?
And no, sir,
Honestly?
like it was
No,
just
no. I completely disagree with you. Why would you mix a pheochromocytoma surgery, which is likely to produce problems, with some other surgery like thyroid? And if you
like
have
that was
radioactive
what
eye, why do you want to
thought
operate on a thyroid at all? So why would you like to operate on a thyroid? From whatever you said, the eye disease was like mild,
a mild eye disease. That was what I
adrenergic
thought
symptom.
initially. I'm telling sir, like that was not a possibility because we could not operate
on both together.
both the things at a time. And as she's having only the mild thyroid eye disease, and we could plan a definitive therapy on the later on date.
Yeah. All right.
I think we'll go ahead, please.
Okay.
So let's wait for time. We'll go
So
on
thank
to
you so much
Arun.
thank you so much for a very nice presentation and very detailed discussion. Thank you so much, Dr. Uday Farke and Shravya. Shravya is going to return after the quiz. So before that, can we just introduce our the information about our ITSCon 2023, which is going to be conducted on May 27th and 28th. Ma'am, a few words about the ITSCon 2023, please.
Thank you, Arun. Thank you. And a very good evening to everyone. It's a privilege for me to release the brochure of the ITSCon 2023. And note, this is the one and only national conference of the Indian Thyroid Society. That is on the 27th and 28th of May. Both the host city, Kochi, also known as God's own country, and the venue, that is La Meridian, are truly exotic. But of course, the most important aspect of any conference is the scientific program, which the scientific committee has formulated, which is highly interactive with a stimulating panoply of scientific presentations. And we have a stellar national and international faculty. The scientific program covers basic science, epidemiology, lab and thyroid, recent advances, the year in thyroidology, future of thyroidology, and there are several symposia from nuclear medicine to surgery to pediatrics, and all sorts of formats are being used for the program. We have didactic lectures, we have panel discussions, and we have Meet the Professor sessions as well. The preceding day, that is Friday the 26th from 1 to 4 p.m., there will be a hands-on thyroid ultrasound workshop by no less than Dr. Susan Mandel and Dr. Krishna Seshadri. So I think this will be really worth it. My suggestion, of course, Arun, is to make it online if possible as well, so we can have a larger attendance if that is doable. And there will be several firsts in this conference. The first is a South Asian Federation of Endocrine Societies Symposium, and FITS or FITS, that is the Fellowship of the Indian Thyroid Society. That will also be awarded for the first time. And the Indian Thyroid Society textbook is also ready. And so Dr. Susan Mandel, who has written a foreword for us, she will also release the textbook during the conference. Thank you, Arun. Thank you for the opportunity, and looking forward to welcoming you all. And this is a physical meeting. This is a physical meeting, and that's also important, which we are doing after a couple of years. The reasons, I think, were very much obvious, but I think everybody is really looking forward to it. Thank you, Arun. Thank you. Welcome to everybody. I hope you will all join us.
Thank you so much, ma'am. So you have very nicely put it all together. I don't think anybody could have done a better job. So
Yeah, we've
we're
got about 40 abstracts so far. I'm sure we are looking
Absolutely,
forward to several more.
So
And of course, I think you'll be telling about the quiz and the abstracts and all towards the
Yes,
end of.
I mean,
Yeah,
absolutely, absolutely.
Thank you so much. Yeah.
So thank you all once again. I'm sure all of you will be part of this conference, and we very much look forward to hosting you in Cochin. So can we move on to the next program of this evening, which is the quiz? And I think Dr. Lohit Kumbar is with us.
Yes, sir. Good evening, sir.
Good evening, Lohit. So, I think I haven't actually talked about the quiz participation rules. Is that what Asmita was going to tell me?
Yes, sir.
So,
Yes, sir.
yeah, so just, I'm sure most of you have attended very many quizzes over the last few months, but just to tell you once again, to participate in the quiz, having a Zoom app on your mobile device or laptop is essential. You're requested to use a laptop for ease of experience. Quiz will run for 10 minutes. There'll be first 2 dummy questions, followed by the actual quiz. The quiz master will display case or description of the question by screen sharing a PowerPoint file. Okay. The participants should use the poll options to participate in the quiz. All 10 questions will be available when the poll is launched, and the answers for all the questions is to be submitted at once at the end of 10 minutes. To read the case or description, you can choose the polls using the X button, and again use the polls option to answer the respective questions. So over to you, Lohit, for taking the quiz forward. Thank you.
Yeah, thank you, sir. Thank you. Yeah, good evening, everyone. So I'll be taking you through the quiz. So there'll be a total of 10 questions as been discussed. So shall I share the screen or okay?
Just
so this is the
one
dummy
before
question.
that, we just have to do the dummy questions. So
Yeah.
we can just have these dummy questions for the trial so that when Dr. Lohit starts, you all know that everything is working. So the first question is, in which city is Taj Mahal? Chennai, Mumbai, Agra, or Bangalore? These are just the dummy questions. And the next question is, how many oceans are there? 8, 5, 6, or 7? So I think now everybody has done it. And now Lohit, Dr. Lohit, you can go ahead. Yeah.
Yeah. So is my screen visible?
Yes, it is visible.
Yes,
Yes.
sir. Yes, sir.
You have, yeah, that's good.
So I'll be going to the first question. So a 35-year-old woman who presented with the thyroid clinic with features of malaise, lethargy, and weight gain of 6 months after delivery. On examination, her pulse rate was around 60 beats per minute, and she was cold, dry, had a dry skin, and systemic examination was normal. So the question is, the presence of which one of the following clinical features has minimal or no impact on the risk of development of postpartum thyroiditis? So A, family history of thyroid dysfunction, lymphoma, C, positive anti-TPO antibody titer, D, previous postpartum thyroiditis. Okay, there'll be only 10 seconds to answer the question. Okay.
Sir, you can move to the second question.
Yeah. So the second question, TSH synthesis and secretion is mainly influenced by serum levels of T3 and T4, but to a certain extent by few hormones and drugs. So to which one of the following medications or hormones stimulates the release of TSH? A, arginine vasopressin, B, dopamine agonist, C, glucocorticoids, D, somatostatin.
Sir, move to the third question.
Yeah. So the third question will be, which one of the following is correct regarding the association of radioiodine therapy and cancer development? So whether it's increased risk of head and neck cancer, carcinoma, B, increased risk of lymphoma, C, increased risk of papillary thyroid carcinoma, D, no increased risk of cancers. So moving on to the fourth question. So I want to know what is the diagnosis in the picture. So first picture is a person with raised hands, and second is the image of the thyroid. Okay. So what is the diagnosis in this condition? So A, anaplastic thyroid carcinoma, B, Graves' disease, C, medullary thyroid carcinoma, D, thyroid lymphoma. Moving on to the fifth question, Voltmann's sign, so which is referred to as delayed relaxation of phase of deep tendon reflex. So which is, I want to know which is not seen in the following conditions. So this Voltmann's sign is not seen in which of the following conditions? So A, hypothyroidism, B, pregnancy, C, anorexia nervosa, D, age less than 1 year. Moving on to the sixth question, a 15-year-old boy who presented with the neck swellings that has been gradually increasing in size. So physical examination was notable for a larger nodule in the infrahyoid area. So, and a smaller nodule in the suprahyoid area. His TSH is 12.6, T3 is 92.9 nanogram per dl, T4 is 6.1 microgram per dl. So what is the diagnosis? So in the A image, you can see there are two swellings marked by two arrows, and the second B image shows the imaging that CT with three marked through black arrows and one with the white arrows. So what is the diagnosis? A, thyroid abscess, B, thyroid ectopia, C, anaplastic thyroid cancer with lymph node metastasis, D, cold abscess. Moving on to the seventh question, a 32-year-old woman who was admitted with the medical assessment unit with nausea, vomiting, and dehydration. She also complained of intermittent headaches and visual blurring. So which one of TFT shows TSH of 4.1, free T4 of 21.3 picomoles per liter, free T3 of 7.1 picomoles per liter. So which one of the following tests may be useful to diagnose TSH OMA? So A 3 mm lesion in the pituitary on MRI, B, blunted or absent response to TRH stimulation, C, decreased alpha subunit to TSH molar ratio, D, low to normal level of SHBG. So moving on to the eighth question. So I want to identify this person in the image. So this person in 1922, he administered iodine in the form of Lugol solution to patients with exophthalmic goiter scheduled for thyroidectomy. With this, the surgical mortality dropped to 4 to 5% at the Mayo Clinic. So this effect was named after him, which described the fact that large intrathyroidal concentrations of iodine inhibit hormone secretion in patients with Graves' disease. A, who is this person? Like A, William Osler, B. Kocher, C. Carl Adolf von Besdorf, D. Henry Stanley Plummer. So moving on to the next question, ninth question. A perimenopausal woman presents with increased swallowing difficulty and fatigue. Her examination shows a thyroid enlargement with lab values showing TSH of 5.5, T4 of 4.9 milligram per dl, free T4 of 2.5 nanogram per dl. TSH immunoglobulins are absent, but antimicrobial antibodies are present. So I want to know which one of the listed histology findings is most consistent with the diagnosis of Hashimoto's thyroiditis. A. Lymphocytic infiltrate without follicular formation. B. Intense lymphoplasmacytic infiltrate with the lymphoid follicles and scattered oxyphil cells. Hyperplasia of the follicular cells with scalloping of colloid at the margin of follicles. D. Granulomatous inflammation with multinucleated giant cells surrounding fragments of colloid. The last question. So which type of collimator is used in thyroid uptake probes? A. Parallel hole, B. Pinhole, C. No collimator, D. Flat field collimator. So with this, we end the quiz. So you can, after clicking on the options, you can find a total, press the submit button all together at once. Answers will be discussed later.
Over to you now for the next case. Shravya?
Shravya, I think you will have to summarize a bit for
Okay, sir.
fitting in the time.
Yeah.
Yes. So over to Shravya for the next case, please.
To the second case, I'm going to discuss about the hyperfunctional thyroid nodule, which posed a diagnostic challenge. 26-year-old female who had a routine health check done in November 2022. She has a complaints of occasional palpitations, no complaints of any headaches, sweatings, weight loss, bowel habits were normal. No significant past medical history. The family history, mother is a known case of primary hypothyroidism. On general physical examination, her weight was 57.5, height of 163.5, BMI of 21.5, pulse rate of 102 per minute, regular, blood pressure of 110 by 70 millimeters of mercury, fine tremors of both the hands present, eyes were normal, neck, there's a palpable right nodule at the lower pole of the thyroid gland. There was no cervical lymphadenopathy, palpable cervical lymphadenopathy. These are all her routine investigations: CBP, electrolytes, renal function test, liver function test were normal. The thyroid function test, which shows TSH of 0.05, total T3 of 298, total T4 of 13.2, free T3 of 5.31 picogram per ml, and free T4 of 3.2 nanogram per dl, which were higher end of the normal, 2 times the upper limit of normal. Serum calcium of 8.7 milligram per dl. As she has a biochemical evidence of hyperthyroidism with we further she got a technician pertectinate thyroid scintigraphy scan done, which shows a dominant hot nodule in the lower pole of her right lobe. This is the picture which is showing her right dominant nodule in the lower pole. She was started on tablet carbimazole 10 mg once daily for the past 3 days by the time she came to us. She came for the second opinion regarding the definitive management. She had a surgeon consultation for which ultrasound neck was done as a preoperative workup, which shows the thyroid nodule was showing suspicious morphological features. The ultrasound neck, the right and left thyroid lobes were normal in size. It shows a solitary, poorly defined heterogeneous hyperechoic lesion of approximately 9 into 14 into 16 mm with multiple hyperechoic calcific focus with marked intraregional vascularity. All these features will account to TIRADS 4. With the hypoechoic lymph nodes in bilateral paratracheal region with absent central fatty island and multiple subcentrometric hypoechoic lymph nodes along the IJV. This is her radiological ultrasonographic imaging, which is showing the right thyroid nodule, which is having the heterogeneous appearance with calcific hyperechoic calcific foci and with marked intralesional vascularity. This is the image which is showing her IJV nodes. This is
according to
Sir.
you in the ultrasound, what do you think is really suspicious?
This calcific foci is suspicious.
And what about the nodes?
Nodes are also on the back. When we consider this node with this thing with hyperechoic lesion with calcifications, these nodes need to be considered things, but it is not showing any feature suggestive of malignancy. Like absent fatty hilum is not suggestive of malignancy, and the size of the lymph nodes were also not so enlarged, and the shape of the lymph nodes, nothing is more in favor of malignant.
Fine. So it's only the calcific focus that makes you
Yes, sir.
suspect that there is something wrong. Okay.
Yes. This is a TIRADS scoring. Her thing is an hyperechoic
4.
lesion with 4. Sir.
Go on. I think this we got
with the TIRADS 4 of size of approximately 1.5 centimeters. She underwent FNAC done, which showed Bethesda class 6, moderate to highly cellular, shows with fibrovascular core, and the few cells shows nuclear grooves with rare intranuclear inclusions, and the few clot shows papillae, which shows focal psammomatous calcifications. The slides of FNAC could not be retrieved because she took it for second opinion. The patient was planned for surgery as it was morphologically suspicious on ultrasound, and with the class 6 Bethesda on FNAC. She was planned for surgery, and the dose of, as she was planned for surgery, the dose of carbimazole was increased to 15 mg per day to have a biochemical cure. Biochemical remission. The patient was biochemically and clinically euthyroid before surgery. She underwent total thyroidectomy with central compartment dissection and right lymph node excision were done. This is the histopathology report, which shows right lobe classic papillary carcinoma of around 1 centimeter. There's no extrathyroidal extension was absent, and all the resected margins were negative carcinoma, and the left lobe and the isthmus were also negative carcinoma. Central compartment nodes and the right jugular nodes, there's no evidence of malignancy. So the staging of the tumor was PT1E because the size is approximately 1 centimeter with no lymph node involvement, N0. This is a histopathological slide, which is showing, which is the low power view and the high power view, which is showing the classic appearance on the high power view with a nuclear thing and few areas of fibrovascular core and the calcified. Coming to the discussion, autonomously hyperfunctioning thyroid nodules represent approximately 5
Just very brief question. Why did you do a total thyroidectomy? And why did you do central compartment dissection?
Sir, total thyroidectomy because that is Bethesda class 6 and which was suspicious for carcinoma. So to have the clearance of the disease, we need to get a total thyroidectomy.
No. So what is the recommendation currently on surgery for papillary carcinoma?
Sir, depending upon the size of the lesion, we go, sir. We go
so
for
what was the size of your lesion?
Size of the lesion was around 1.5
1.5.
centimeter.
So does it really necessitate a total thyroidectomy?
It does not, as per the recent recommendation, it does not necessitate the total thyroidectomy, sir, but it depends on the patient's. We give an option if we do an hemithyroidectomy, and she should be on the lifelong follow-up of the with the regular ultrasonographic examination of her other thing to find out any recurrence of her nodules in the.
Yeah. So what is the recurrence rate in hemithyroidectomies done for 1.5 centimeters papillary tumors? So
Recurrence
otherwise,
is-
you'll have to do total thyroidectomies for each and every patient by this logic. But this patient also had Graves, no?
Yes, sir.
So then how would a hemithyroidectomy work for that patient? If you were considering,
Yes,
she wanted definitive therapy for Graves
Therapy.
also, right?
yes, yes.
So then what's the point in doing the hemithyroidectomy in that scenario? So
Yes.
here, if you wanted to control a thyrotoxicosis or cure a thyrotoxicosis as well, that's why probably it was decided to do a total thyroidectomy. I think Dr. Mehrotra is here, he will agree with me, right?
She had toxic nodule. She didn't have Graves' disease.
Oh, she had a toxic nodule, but the uptake is actually quite diffuse. It's not restricted to the nodule really.
Calculation of this score that was basically more focused to the. It looks like a diffuse, but this is focused only on the right side.
Okay, and why central compartment dissection?
It was basically a surgical decision to on the table to decide to go ahead.
Okay, fine. All right, go ahead.
Autonomous hyperfunctioning thyroid nodules are approximately 5 to 10% of all the thyroid nodules. These so-called hot nodules are defined by the increased radiotracer uptake compared to the surrounding thyroid parenchyma. Hot nodules can exist as a single or the multiple, which is toxic multinodular goiter. The degree of autonomous hyperfunctioning of the hot nodules is variable. This hyperfunctioning thyroid nodules grow independently irrespective of the TSH thing and in the absence of TSH receptor antibodies. The classic appearance observed on thyroid scintigraphy is a circumscribed hyperdense lesion surrounded by the hypodense thyroid tissue. The hyperfunctioning thyroid nodule can be classified as a benign or malignant. Compared to the non-toxic nodules, the hot nodules are traditionally believed to be exceptionally have a lower rate of malignancy. But recent studies have challenged the presumed low risk of malignancy in hot nodules, suggesting that the incidence of cancer has been underestimated in hot nodules. This is the 2015 guidelines of American Thyroid Association. The recommendation, they recommend the serum TSH should be measured during the initial evaluation of patient with thyroid nodule. If the serum TSH is subnormal, then we proceed with the radionuclide thyroid scan should be performed. Depending upon the serum TSH value, if the serum TSH is low, then we get a radionuclide thyroid scan, and usually we don't do an ultrasound if the serum TSH is low as per these recommendations. This is the picture. If the thyroid nodule, we get the initial serum TSH done. If the serum TSH is low, we get a thyroid scintigraphy scan done. If it is a hot nodule, we either treat them with antithyroid drugs or radioiodine ablation or the surgery, depending upon the clinical situation. If the serum TSH is high, we get ultrasonography done, and depending upon the TIRADS staging and the size of the lesion, we proceed with the FNAC. This is a similar flowchart which is showing whom to undergo FNAC, which lesion should undergo FNAC, which should not be. This is the case report of papillary thyroid carcinoma in autonomous hyperfunctioning thyroid nodule, which is a case report and review of literature. Summary of this is a 11-year-old girl who presented with menorrhagia, fatigue, and right thyroid nodule. On evaluation, her TSH was undetectable. The scintigraphy shows AFT and autonomous functioning thyroid nodule. They even did an ultrasound which shows a non-homogeneous nodule. They further proceeded with FNAC, which could not rule out the malignancy. So she underwent right hemithyroidectomy. The final histopathology report turned out to be papillary thyroid carcinoma. On the later date, she underwent left completion thyroidectomy. So the conclusion of this report was detection of autonomous functioning thyroid nodule in children and adolescents that does not exclude the possibility of thyroid carcinoma and warrants careful evaluation on appropriate therapy. One Japanese study reported that among 17 patients with AFTNs, thyroid carcinoma was identified in 2 individuals. Yet other reports suggest higher incidence of thyroid cancer nodules detected in adults with Graves' disease, were detected in 245 consecutive previously untreated Korean adults with hyperthyroidism. The longitudinal changes in autonomous, this is another case report, which was longitudinal changes in autonomous functioning thyroid nodule with coexisting follicular thyroid carcinoma over 14 years. This was done retrospectively. She had, this female had a right-sided thyroid nodule, which was followed up. Initial, her thyroid function test was normal. Over a duration, there is an increase in the size of the nodule with the compressive symptoms. At that time, she was initial size of the lesion was 13 mm, which got increased to 33 mm. She has the symptoms of thyrotoxic symptoms with biochemical evidence of hyperthyroidism. So she underwent thyroidectomy, which turned out to be follicular thyroid carcinoma. This is a recent thing which is showing malignancy risk of hyperfunctioning thyroid nodules compared with non-toxic nodules, which is a systemic review and meta-analysis. There they have studied like different case series. This is a systemic review and meta-analysis of different case series. The odds ratio of malignancy risk of single hot thyroid nodules compared with single non-toxic nodules. In all the studies, the risk is more in the non-toxic nodules. Only in one study it shows the bias. The risk is more in the hot nodules. This is the pooled odd ratio of the malignancy risk of hot nodules. This is the single hot thyroid nodule. This is the multiple hot nodules, where only this study shows the increased risk in hot nodules when compared to the cold nodules. This summary of 62 case reports, which was a systemic review and meta-analysis, where autonomous functioning thyroid nodule was turned out to be papillary thyroid CA in few case reports, and it can be follicular thyroid carcinoma in other case reports. This systemic review demonstrates that the odds of malignancy in hot nodules are reduced by 49 to 62% compared to the cold nodules. However, the overall rate of malignancy observed in hot nodules is higher in this systemic review. Higher incidence of malignancy in hot nodules was observed in 7 included studies, ranges between 10 to 34%. The pathogenesis, the genomic instability plays an essential role in the progression of thyroid neoplasms, such as papillary thyroid carcinoma, follicular or differentiated thyroid carcinoma, or anaplastic thyroid carcinoma. The frequent genetic events are seen in BRAF, HN, and KRAS, and TSH receptor mutations. Concomitant activation of oncogenes, that is activation of TSH receptor, cyclic AMP cascade, played an important role in the carcinogenesis of the hyperfunctioning thyroid nodule. This is the activation of the G-stimulatory alpha was reported in Lyons et al. In the hyperfunctioning follicular adenoma, whereas in other cases, Parma et al. Identified constitutively activating mutations in the TSH receptors. This is the recent case report, which is showing that the hyperfunctioning papillary thyroid carcinoma who had a mutational analysis which shows BRAF mutation. This is the first case report. The literature search yielded 16 cases of hyperfunctioning thyroid carcinoma, wherein mutation analysis was conducted. The TSH receptor mutations were identified in 13 of these cases. Notably, one revealed a mutation in both TSH receptor and the KRAS, whereas other revealed a mutation in TSH receptor with the rearrangement of the PAX8 and PPAR gamma. This case report showed a mutation in BRAF B600 is replaced by B600E mutation. Is the most common type of BRAF mutation in papillary thyroid carcinoma. American Thyroid Association management guidelines for patients with thyroid nodules recommend that no cytological evaluation is necessary if the serum TSH is suboptimal. In contrast, Japanese Thyroid Association management guidelines for this disorder recommend that FNAC is mandatory based on ultrasonographic findings, but not serum TSH levels. This discrepancy may be due to the higher incidence of malignant see malignancy in the hyperfunctioning thyroid nodules, 5.1 to 11.8% in different case series reported in Japanese population compared to the Western population. Although the incidence of hyperfunctioning carcinoma is low in Western populations, ultrasound followed by FNAC may play an important role. However, the mainstay of treatment of thyroid carcinoma with concomitant hyperthyroidism is surgery. It not only confirms the condition after a pathological examination, but it removes the cancer and resolves the use of antithyroid drugs as a hyperthyroidism treatment. Coming back to the case, she's a T1A stage, a tumor of around 1 centimeter without any extrathyroidal extension. So she's a candidate of, she's a low risk candidate. So she did not undergo any radioiodine therapy. Learning point from this case is the incidence of malignancy reported in hot nodules was higher than the expected. These findings highlight the need for further studies into the malignancy risk of hot nodules. Thank you.
Thank you. Thank you for that excellent case. So that is the real learning point, that go by the ultrasound, not just the TSH value. And if the ultrasound is suspicious, do still go ahead with FNAC. But in general, Japanese series always report higher thyroid carcinomas than the West. So there could be some bias there. But still, nevertheless, this case opens up that possibility that if the ultrasound is abnormal, you should still consider a biopsy of that lesion. Thank you.
Okay, Arun.
No more question as such.
Yeah.
Any
I think
points?
we'll go ahead with the answers to the quiz, or you want the abstracts first, or?
I think after the answers to quiz, we can, or maybe we can have the abstract. So
I think it's a good idea to have it now.
For the slides, yes.
Yes.
By the time Dr. Lohit gets ready, then we'll just show the important deadlines. And so the call for abstract for the Indian Thyroid Society, I mean, as Madam had said earlier, we've already had more than 40 abstract submissions into 3 different categories. So there is, please note that it's not only just for postgraduates and trainees, there is also one for practitioners. So that 3 different categories. So please do send in your abstracts, and there are attractive prices as well for that. So the last date of submission is 15th as things stand. The second important announcement is about this thyroid ultrasound workshop that again Madam had mentioned about. We have got, if you're registering for the workshop, there is a discounted rate for the registration for the conference. So please take a note. This is now active on the website. So if you go into the website, you can register for the conference as well as the workshop. So you can only, for workshop registration, you have to register for the conference as well. That goes without saying. And the third highlight is our young brigade who is going to conduct this quiz. I think they have been preparing for many weeks now already. So I think they're very, very enthusiastic. You know, all these people, Dr. Om Lakhani, Dr. Lakshmi, Dr. Vimal, Dr. Mohan Shanai, and Kaushik Biswas. So this should be a highlight of the conference. So please register for the, so there is no, again, I would like to tell you that there is no online quiz there. This is a physical one, it's a physical meeting. So please do try to attend the meeting if that's possible, and be part of that quiz as well. Thank you. So over to you, Dr. Lohit, for we're all looking for, anxiously waiting for those answers.
Yes, sir. Yes, sir. Sure. Yeah, I'll be discussing regarding the answers. So the first question was talking about the what was the minimal or no impact on development of postpartum thyroiditis. The answer is lymphoma. So all other options are a risk of developing postpartum thyroiditis. Lymphoma has minimal or no impact on this. So second question. So the answer was arginine vasopressin. Arginine vasopressin will stimulate the release of TSH. dopamine agonists, glucocorticoids, and somatostatin, they inhibit the release of TSH. Third question regarding the radiation therapy and cancer development. As of such, there are no any increased risk of cancers associated. So answer will be the D, no increased risk of cancers. Fourth question. So this in the picture, so you can see the answer is Graves' disease. So there's a lid retraction in the first picture and goiter and jugular venous distension and imaging showing thyroid enlargement, thyroidomegaly. So the diagnosis is Graves' disease in this fourth question. So regarding the Voltman sign, the answer is age less than 1 year. So advanced age has in such patients, the Voltman sign is seen, but not in age less than 1 year. All other conditions, there is a Voltman sign are seen in this. So regarding the sixth question, so there's a this answer is thyroid ectopia. So the two black arrows are these two ectopic thyroid tissue which are homogeneous, and the white arrow is like non hypodense on imaging. So it is there was no any normal thyroid tissue. It is a ectopic thyroid tissue. So the answer will be thyroid ectopia in this condition. So this was a clear-cut TSH-OMA. So to diagnose TSH-OMA, we need a blunted or absent response to TRS stimulation. So the C option will be like it will be increased alpha subunit to TSH molar ratio, and SHBG will be increased in such condition. And usually the MRI, usually the higher the larger size of the lesion in pituitary MRI will be seen. So the answer here will be B, blunted or absent response to TRH stimulation. So this person like is a Henry Stanley Plummer. So it is named after his, that is the Plummer effect has been named after this person. Ninth question, Hashimoto's thyroid is easy one. So intense lymphocytic, lymphoplasmacytic infiltrate with lymphoid follicles and scattered oxyphil cells are seen in Hashimoto's thyroiditis. Last one, the collimator which is used in thyroid uptake is the pinhole that is most commonly used, which has a very good imaging modality with pinhole. So thank you for the answers.
So Asmita, you will now display the winners. So the quiz winners are Dr. Anis Joseph, Dr. Parag Agarwal, and Dr. Sagar Saurabh. That's great. Excellent.
We're missing Bharti today. You, Pramila.
Oh, Sagar is also our resident.
Oh, but Parag is also one of the regulars.
Ah, yeah.
We have some
True.
regular participants.
Winners and winners.
I think between the two of them, they decided we'll not participate. One of us will only. So that's nice.
So thank you. I think that brings us to the end of this session. The upcoming meetings, the next one will be on 10th of May 2023. And then again, it follows on a monthly basis from then on. And not to forget, again, we will remind you on the 10th of May, we are hoping to have also a World Thyroid Day online session, which is being planned. I'm sure we'll plan that and inform you by 10th of May. That will be on 25th of May. And that will be followed, of course, by the major mega event, which is on 27th and 28th. So signing off. Ma'am, last words, do you want to say anything?
So I want to say just thank you for inviting me to this very fascinating session. So thank you, Dr. Mehrotra, Dr. Bajaj, Dr. Menon, and also Dr. Shravya for that presentation. So it was really a pleasure. Thank you.
Thank you, Day, and thank you, Dr. Mehrotra, for a
I think
wonderful.
I will allow Pramila to have the last word for a change. Usually I have the last word.
No, ma'am, you will have to have the last word. But I will just say that all the abstracts which you people are submitting, everybody please submit your abstracts for ITSCon, which is the national conference of our Indian Thyroid Society. And these abstracts will come in the next issue of Thyroid Research and Practice, which is the official journal of Indian Thyroid Society. So please submit your abstracts. We still have time till 15th April. So as many abstracts will come, we will again, it's, put some for oral and some for abstracts for the poster. So kindly submit your abstracts because they will all come in the Thyroid Research and Practice next issue. So that's the most important thing. So please submit it so that you can get the publication there of your abstracts. And yes, later on, you can obviously also send your full text articles to Thyroid Research and Practice. We are accepting all full text articles. Also, we are accepting some reviews also, but that they all will be peer reviewed and published. So if you have case reports, if you have full text articles, if you have some review articles, please send it to us. We'll get the peer review done, and then if found suitable, they'll be accepted for publication.
Thank you, Pramila.
Yeah.
I think we can.
Thank you. So I think I should really thank everybody. I didn't really know that there was one DNB candidate in. So this is also a first for the Indian Thyroid Society Wednesday clinics, because invariably we have 2 case presentations. We had 2 different residents. So Shravya had a lot on her shoulders, but I think she's carried it off very well.
Yeah.
And thank you, Uday, for grilling her. Uday was really grilling her so well.
But lot of
Sorry,
hard
so
work.
I didn't mean to grill her. I just wanted
No,
to
that is the
push her a
idea.
little.
That's the whole
No, that is
purpose.
the whole idea.
You've done a great
I
job.
didn't mean
You've done a
grill.
great job.
I mean, of course, she has to still have the exams yet, isn't it, Ravi?
Thank you,
She's
ma'am.
only first year, so I think she has got a lot of time.
I think she's
So
done
great.
exceedingly well. So congratulations, Rabia. And both the cases had, tremendous learning points. So like we know the association between hyperthyroidism and hypertension, but then to keep your mind open to other differential possibilities, knowing the common causes of endocrine hypertension, which they had highlighted brilliantly. I think hats off to you for the excellent discussion in both the cases, the hyperfunctioning thyroid nodule, which was a challenge, and hyperthyroidism presenting with pheochromocytoma. I just wondering, I mean, you didn't find any case series. What you found were just case reports, right?
For the few,
Yeah.
only the case reports. We didn't find the series. But for the
Yeah, that's what I'm saying.
with cancer, the case series are coming up now.
Great. So I think Pramila will be very happy if you publish it in our journal, if you think it's appropriate. We're always welcoming, isn't it? That is
We're waiting for
the
final
idea.
report. We're waiting for the microbiology reports and the for repeat track. And when those reports come in, then we'll definitely publish after that.
But we'll be very happy to have those publications in the ITS journal. And of course, thank you, Ravinder, for chairing. Thank you, Uday, for the excellent moderation. And I think that was a great quiz, Lohit. And then we have our regular, the secretary, that is Arun, Pramila, who's the scientific chairperson for all the meetings that we are organizing, Minnie, who's our treasurer, and congratulations to Anis, Parag, and Sagar. Parag is again a regular. And like Pramila says, from her institute, if we don't have the quiz, then we will have a complaint cell set up. So I think it's been great. And thank you to Asmita, who's with us from the digital team. And from Medisage, we have Vidhi with us. Thank you, Bhavesh, for joining us today. And it's a pleasure to we look forward. It's a pleasure to have presented the ITS Con brochure. And we really look forward to having everyone with us. Good night. Good night. Thank you.
Good night, all.
Good night, everyone.
Thank you.
Good night.
And the only just last word is about the meetings. The dates are odd, but it's a Wednesday. It's a Wednesday in the middle of the month. So just remember the Wednesdays. So we'll keep on informing you about subsequent meetings. Thank you. Thank you. Thank you so much. Good night.
Thank you.